morning everyone. So being the first session of the day, I think everybody is still little lethargic. So we'll have to give a boost of IV iron for everybody to pick up their energy levels. So I'll try to make this as interesting as possible. Despite our main discussion would be regarding the pre-FAIRHF2 era. So as the title goes, the FAIRHF2 trial was recently presented in the ACC 2025, so which is being seen as another landmark journey in the development or progression of IV iron therapy, especially in patients with heart failure. So in patients with heart failure, we all know about the 4 pillars of heart failure therapy, but the neglected ones such as the IV iron and the diuretics also have to be discussed regularly, because I feel if not the pillars, these form the foundation of heart failure therapy. So today we'll be discussing about the basic outlines such as the burden of iron deficiency in India and the trials for the pre-FAIRHF2, what are the limitations of these evidence, the meta-analysis, the safety of IV iron, the guideline positioning, and the implementation and economics in the present Indian scenario. So we all know once we go to iron deficiency, we have 2 forms of iron deficiency. One is the absolute iron deficiency and the second is a functional iron deficiency. So, and this is not synonymous with iron deficiency anemia. So that is what these all trials or the data will also show, that iron deficiency in heart failure is separate from iron deficiency anemia. That means all patients of iron deficiency need not have anemia. And it is imperative to diagnose iron deficiency for effective treatment and reduction in heart failure burden in these patients. So absolute iron deficiency is defined as ferritin of less than 100 is a form where the iron stores in the body are less, and the second is a functional deficiency where the storage forms of ferritin may be normal, that is between 100 to 300, but transferrin saturation, that is the protein which transports the iron, is less. So coming to the Indian population, the Indian burden, this was study in Vellore of 2025 of 283 in patients. So you can see the iron deficiency prevalence was 84.4, and this is a very important point, that is non-anemic iron deficiency is 24%. That means if you would consider hemoglobin as a marker of iron deficiency, then you would miss almost 24% of the patients. And anemia was seen in 76% of the patients, and iron deficiency was more common in NYHA class 3 and 4 males. So the other study of the AFMS in 2022 of 204 heart failure with reduced ejection fraction with a mean age of 63. So again you can see the iron deficiency prevalence was 88.7, of which absolute was 83 and functional was only 5, and anemia was only 70%. So again a mismatch between the anemia and iron deficiency prevalence. And there are other markers of iron deficiency which can be seen in the 2D echo by the elevated E by E prime, or you can see a diastolic heart failure. And this highlights the iron deficiency burden extending beyond anemia in patients with reduced ejection fraction in the Indian population. So another trial which was done in Rajasthan in 2016 of 150 heart failure patients, again you can see that iron deficiency was seen in 76% of the patients, but here the functional iron deficiency was relatively higher in 27%, but again the non-anemic iron deficiency was seen in almost 24% of the patients. And women were disproportionately affected, 91% compared to 68% of males. And this iron deficiency was present even in preserved ejection fraction and across NYHA class 3 and 4. So another small study coming from Himachal Pradesh. Again, the point to be highlighted is the discrepancy between iron deficiency having anemia and the non-anemic patients, which is again 58% versus 35%. And this study showed that low hemoglobin and a low transferrin saturation was strongly linked with an advanced heart failure. So the National Heart Failure Registry from 22 to 25, so basically these are the different classes which included heart failure to reduce ejection fraction and guideline-directed medical therapy. And coming to the last one, which is a heart failure with preserved ejection fraction. So basically, the best outcomes were seen in patients with a mildly reduced ejection fraction, that is with an ejection fraction of between 40 to 50 and who are on guideline-directed medical therapy. So this is the patient population which did best with least mortality, and the highest mortality was with reduced ejection fraction and who are not on guideline-directed medical treatment. And you can see the 90-day outcomes, the mortality was almost 14.2% and a rehospitalization of 8.4%, and 1-year outcome mortality was 22%, which confirms a high early mortality and rehospitalization risk in the Indian heart failure patients. And it also reflects a gap in optimal guideline-directed medical therapy and supportive healthcare. So the heart failure burden in the Indian population is high, especially in patients with iron deficiency and who are not receiving guideline-directed medical therapy, be it those with reduced ejection fraction and preserved ejection fraction. So, various trials indicating the need for iron supplementation, be it oral or IV, which were done, and the latest FAIRHF2 presented in the ACC 25. So we would like to take a trip down memory lane of how exactly did we come to this FAIRHF2 trial. So initially started with the FAIRHF, which was started or published in the NEJM 2009, an article which was a multi-center, double-blind, randomized control trial of 459 patients, and they had given IV ferric carboxymaltose versus placebo, and it has shown NYHA class improvement of 47% in the trial group compared to the placebo group, with an improvement in 6-minute walk test and quality of life. And adverse effects were similar compared to placebo. And the key message from this trial was, this was the first randomized control trial to prove that IV iron improves symptoms, exercise capacity, and quality of life in heart failure, irrespective of anemia status. But this did not meet the mortality outcomes on cardiovascular mortality, so did not achieve that. So it was only improvement in symptom outcomes and reduced risk of hospitalization. And many of the patients in the trial showed significant improvement in functional status and quality of life. So from 2009, we come to 2015. So the European Heart Journal, the CONFIRM-HF trial, was again a multi-center randomized control trial with a primary endpoint of 6-minute walk test, and it showed improvements in NYHA class and quality of life and fatigue score and reduced hospitalizations, but again was neutral for mortality benefit. So you can see the 6-minute walk test significantly improved in patients with IV carboxymaltose, that is FCM, for 52 weeks, and improvement in self-reported quality of life and symptoms also. So 2017, again published in Circulation, the EFFECT-HF was a multi-center randomized control trial, though a small population of 172 patients, 1-to-1 randomization with FCM versus placebo, and this was the study which showed a change in peak VO2, that is 24 weeks of cardiopulmonary exercise testing. This was the only study which used the objective benefit of cardiopulmonary exercise testing and showed that ferric carboxymaltose prevented decline in exercise capacity, and which was again mortality driven was uncertain. So peak VO2 was significantly less or improved in patients who had received IV ferric carboxymaltose as compared with placebo, and significant NYHA class improvement, and NT-proBNP also there was a small rise with ferric carboxymaltose as compared with the placebo, those not significant. So the other, coming to the 2020, the era of COVID, the AHF was again a multi-center randomized control trial with almost 1,100 patients, randomized to IV ferric carboxymaltose compared to placebo, and total hospitalization and cardiovascular deaths were less in the IV iron group compared to the placebo group, though p-value was borderline significant, and secondary outcomes of total heart failure and first heart failure hospitalization was also significantly less. And the message from this trial was ferric carboxymaltose reduced heart failure rehospitalization but again did not show significant mortality benefit. So reduction in hospitalization was seen, but mortality benefit or cardiovascular death was not significant as compared with the placebo group. So 2022, the Ironman trial with a population of 1,137 in the UK trial. So again, quality of life improvement was shown, which confirms safety and efficacy and supports the use of IV iron in the broad heart failure patient. So the HeartFit trial, again NEJM 2023 is a multi-center randomized trial, used ferric carboxymaltose versus placebo, and the primary endpoint was a composite of 12-month death and hospitalization. So again, hospitalizations were lower with the ferric carboxymaltose, and 6-minute walk test was also improved, but again, mortality, no significant benefit. So the key message is, though the mortality was neutral, benefit was neutral, the trial reinforces the IV iron role as a morbidity reducing therapy in patients with heart failure with reduced ejection fraction. So there are again some other trials, which was the Iron Out trial in the JAMA 2017, which used another IV iron therapy, but again similar, no mortality benefit, but reduce in risk of rehospitalizations. So coming to the summary of all the trials, which in the pre-FAIRHF2 data, which showed reduction in peak VO2 and a 6-minute walk difference was slightly better in the IV iron group. But the points to be noted is the adherence with IV iron was better, and there were issues with oral iron therapy because of the side effects, and the safety profile was very good with similar adverse effects even in the placebo group. And the key message to be noted here is the oral iron was ineffective as compared with the IV iron, and this reinforces the superiority of IV iron supplementation. So the main mechanism for this is they consider what we call a hepcidin block. That is, when you consider the iron deficiency as a chronic inflammatory condition, the hepcidin prevents the absorption of oral iron, and when you give IV iron, this overcomes the hepcidin block by increasing the ferroportin channels and intracellular absorption of IV iron. And in the trials, the FAIRHF2 trial, basically they were randomized trials, but the sample size was only moderate, underpowered for mortality and hospital-driven composite benefits, and no Indian outcome-powered randomized controlled trials were seen. There's various meta-analysis from the 22 to 25 era, which showed decreased hospitalization, but again neutral on cardiovascular mortality. And there's a 21% relative risk reduction in cardiovascular death or heart failure hospitalization, and was consistent across all the iron IV formulations, be it ferric carboxymaltose or desomaltose. So the other randomized basically meta-analysis in 24, which reinforces the safety profile and confirms the class effect of IV iron in reducing mortality and symptom benefit. And there's a key message from the meta-analysis suggests robust morbidity benefit, but no mortality benefit, but safety is again well established. So the safety evidence from all the trials showed that the hypersensitivity was less than 1%, and the Ironman, the Affirm, and the HeartFit trial showed significant safety, and also that IV iron was consistently safe, but oral iron was again ineffective. So based on these trials, the guidelines, the ESC 2023 state that Class 1A, IV iron in symptomatic heart failure with reduced ejection fraction with iron deficiency to improve quality of life and exercise capacity, and Class 2A for reducing heart failure rehospitalization. So again, the diagnostic threshold, let me reaffirm that ferritin less than 100, and if it is between 100 to 300, should look at transferrin saturation if it is less than 20%. So less than 100 ferritin is absolute iron deficiency, whereas with 100 to 200 with transferrin saturation less than 20% is relative iron deficiency or functional iron deficiency. So the AHA 2022 heart failure guidelines say Class 2A for IV iron therapy, which is reasonable in symptomatic heart failure with reduced ejection fraction and iron deficiency, with the similar diagnostic thresholds as per the ESC guidelines. So the key message would be the guideline coverage and routine iron deficiency screening in heart failure and IV iron use for symptom benefit and morbidity benefit. And though the mortality benefit is not established, it is reflected in class of recommendation. So coming to the Indian population, there are no outcome-powered Indian randomized controlled trials. There is high prevalence of iron deficiency, but data is limited to cohorts, and there is need for pragmatic local trials to confirm the outcomes of IV iron therapy. So coming to the Indian scenario, we have seen a lot of implementation and logistic challenges. So there is a disparity in the public and private sector for the access to IV iron therapy, maybe because of the cost or because of administration issues, and there is need for streamlined infusion pathways in the Indian scenario. So the economic burden, so maybe in the Western population it is not highly economy dependent, but in the Indian population, when you go to the government or state-run setups, there is a significant burden, and a high heart failure rehospitalization burden leads to greater relative benefit and strong cost effectiveness case for adoption in both public and private healthcare, and opportunity to integrate in the state-run schemes will help in reducing the iron deficiency and preventing or improving the outcomes in patients with heart failure, especially reduced ejection fraction. So coming to the end of our discussion, so the pre-FAIRHF2 trial, basically the era before this, that is 2025, has shown IV iron to have proven symptomatic and rehospitalization benefit, but the mortality question remains unanswered. And the bridge to FAIRHF2 trial, the definitive outcomes are awaited. And coming to the Indian population, we have a high burden, high generalizability, and there is an urgent need for local validation by randomized trials and assessment of the IV iron therapy in patients with heart failure, and how it affects the Indian population is the need of the hour. So, thank you very much.